Hello and welcome to the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Our guest today is Dr. Briana Walton. She's a urogynecologist. That doesn't mean you're a European gynecologist.
It does not.
And you're the director of the Women's Center for Pelvic Health?
Yes, I am.
In Annapolis, the Anne Arundel Medical Center.
That is correct. Thank you so much for having me.
I am so happy to have you because there are a lot of women nowadays who suffer with bladder issues. And I know, starting out, because I've had my issues with that in the past, years ago, there weren't a lot of people like you. There weren't a lot of doctors like you.
Absolutely. I mean, as a subspecialty, we just became a board-certified subspecialty in 2013. So there aren't a lot of us around, and there certainly aren't a lot of women who provide this kind of care. Most of the medical community isn't even familiar with sort of the convergence of the two specialties. And you could probably say three specialties because we not only deal with urinary and gynecologic issues, but also colorectal.
When we're talking about, for example, bladder issues, we see a lot of commercials on TV now, a lot of drugs that are available that weren't available before. Are we seeing more cases nowadays, or is it being diagnosed correctly?
I think, so the numbers are about 1 in 4 women will have some sort of pelvic floor disorder, which is either bowel, bladder, or prolapse, meaning things are herniating or protruding. But the more common thing that has happened is that we've got more medications, and so it has become much more popular to see on TV these commercials that talk about these issues. I actually think it's very helpful, even if you don't start the medications, because now women are like, oh, this must be common, because every 5 minutes there's a commercial about bladder control issues.
So is this an issue that we see affecting young women, women who are menopausal, or everything in between?
It is more of an everything in between, but the more common time frame is over the age of 55, where, you know, for all comers it's about 1 in 4, but for women over 55 it's about 1 in 3.
So what's happening? Is it because of childbearing? Is it because your body's going through so many changes because of menopause? What's happening?
I think it's all the above. So, you know, what's interesting is the effect of childbearing on the body and the pelvis. Our bodies are able to compensate for those for periods of time. But as we start to get these hits, you know, with menopause and the lower amounts of estrogen, which affect collagen, and that affects tone, or we become more sedentary, and so our pelvic floor muscles, not just our muscles, but our pelvic floor muscles atrophy, they thin out. And we're ignoring some of these issues because we feel like, well, this is just kind of what happens. That's what our grandmothers told us, that's what sometimes even our moms told us, but it's not normal. It's common, but it's not normal.
Well, a lot of times you don't get told anything. So you're just kind of stumbling through this thing.
I agree.
So what should we do, or what effect does diet have, what we're eating? What effect does that have on your system?
So a lot of us tend to propel ourselves with caffeine, right? We wake up in the morning, we got to have our coffee, or we have to have our tea in order to get ourselves going. And unfortunately, caffeine is a bladder irritant, and it can make us go to the bathroom a lot more often than we should. Some will even try to compensate for sugar, you know, try to use a sugar alternative to cut down on the calories, which makes sense, but that's also a bladder irritant. So, you know, we start off early in the morning doing these things that already are negative for our bodies. And then I think also just we have a tendency to be overweight. You know, as we've looked at the demographics across the United States, we've gotten heavier and heavier and heavier. And that impacts the ability for your pelvic floor muscles to really compensate for those stresses and pressures that it would normally have to feel if you were normal weight.
I want to come back to the whole obesity issue in a few moments, but there are also some other foods, things that are acidic, things like chocolate.
Yeah, so it's a big surprise,
How
isn't it?
could chocolate How could chocolate do something like that? How could chocolate be an irritant to anything or anyone?
Well, it is an irritant, but I think in moderation. For the garden variety person, they can tolerate it. But for someone who has more sensitivity of their bladder, it's one of those things that can trigger bladder spasms. They can trigger another condition called interstitial cystitis, which can be basically like present like a urinary tract infection. It feels bad. You go frequently, you go urgently, but you go and have the test and nothing shows up. So it's one of those things that a lot of our primary care doctors scratch their head and like, I don't understand why you have these symptoms, but I can't prove it on a urinary tract infection test. So,
so should you stay away from these foods completely?
I don't think
or
that's
can
necessary.
you do it in moderation?
I think you have to do it in moderation, and you have to know what your triggers are. If you know you're going to a party and alcohol affects you and the number of times that you're going to go to the bathroom, you want to moderate how much you're going to drink or time when you're going to have alcohol intake.
What is the normal time? How many times a day should you
Good point.
go to the bathroom?
So a normal number of times is less than 8 times per day, from the time you wake up to the time you go to bed. And if you're waking up more than 2 times at night, that's considered nocturia, or nighttime urination, which for us, that is a major problem with our seniors, because that is an independent risk factor for falls, hip fractures, and other untoward events that we don't want to happen to our older adults.
So you shouldn't go to bathroom more than
2 times.
And if you think something's going on, at what point should you go see a physician? When you spend too much time in the bathroom.
Right. I think if it bothers you, it bothers us. That's one of the main points, is that if there is a question about it, you should ask. A lot of women are being cared for not just by their OBGYNs, but their primary care doctors. And so the primary care community is getting more used to referring to urogynecologists and urologists for the frequency and urgency. I think, again, those commercials have been very helpful because they help educate the public about what are the conditions that are very common. And so people come in a little more knowledgeable about, I need to have a referral or this medication because I have this problem.
So we've talked about a couple of things. We've talked about overactive bladder, and you talked about bladder infections, UTIs? Or
Correct.
What they call. And then there's the other one I can never pronounce, the cystational.
Cystitis.
Go ahead and say it.
Interstitial cystitis.
What's the difference?
So it's a non-inflammatory, it's an inflammatory condition, but a non-infectious. So there's no bacteria that causes symptoms of a urinary tract infection, but you don't actually have one. So the triad is PUF, pain, urgency, and frequency, versus overactive bladder, where you're having too much fun. Frequency, urgency, and nocturia, or nighttime urination.
Do you find that some of these are hereditary? Do you find that if your mother had that, then you possibly have it, or maybe sisters have it? Or
I think it's really common for families to have it, but when you dial it back as the possible source for some of these issues, like for example, overactive bladder can be the result of fibroids. And for women of color, we're about 50% of us have fibroids. And so you
Isn't
might,
that incredible?
right, like so you could present not with bleeding problems, but with going to the bathroom too often. You could try all the different medications, it not work. You could try exercises, it not work, and you, lo and behold, you have a big uterus or big masses inside of your uterus causing problems.
Wow, I didn't know that there was a connection.
Yes.
Between that, because we know, I mean, fibroids, they're at an epidemic level.
Absolutely.
Among African American women.
Absolutely.
Do you find that that these diseases as well are at epidemic levels with African American women, or is there any data available saying that maybe African American women suffer at a disproportionate rate?
Not necessarily for overactive bladder, but I think one of the probably more key principles is that for fibroids in particular, the presentation of them can be very wide. You know, bleeding problems, sexual problems, pain problems, urinary problems, bowel problems. And so we don't always kind of dial it back and say, it's the fibroids causing all these issues. And when you think about a condition that affects 50% of people, one of those things could potentially be hit. Now, most women who have fibroids are not symptomatic, but it's one of those things that as we start to, so if you don't mind me saying this, a lot of times after women have babies and they've completed sort of their childbearing, they start to see other providers. And sometimes those exams aren't necessarily at the level that a gynecologist would do. And so their ability to pick up those fibroids is limited. Or if you're holding a little extra weight there, you can't actually feel it. So one of the things that we are trying to encourage women to do is ask better questions when they go to their physicians.
That's always been an issue, especially among African Americans. We go into the doctor's office unprepared.
Correct.
We don't know what to ask, and we listen to whatever they say without any...
Well, I think we consider it disrespectful in some ways, so culturally, that if you're not supposed to question the doctor, but it's a partnership.
Indeed.
It's supposed to be a relationship where you're walking together, figuring this out, because it's history, right? It's his story or her story, not my story.
Let's go back to the obesity issue. How does obesity affect you gynecologically as well as your bladder, your urinary tract system?
So just some generalities. So when we are overweight, you are carrying that extra pressure, and I think many people are comfortable understanding like the impact on your joints, right? They get it. They understand the impact with like orthopedic issues, but they don't really get it about the impact on your pelvic floor and how it has to compensate for those things. The intra-abdominal pressure, or the pressure that is generated when we walk and when we move, it hits our pelvic floor every single time, just like it has to go down those legs. So the more weight we carry, the more impact it can have on our pelvic floor. And sometimes those muscles, which kind of sit together. So can I use this room as an example? If we're in the vagina right now, okay, and the ceiling is the bladder and the floor is where the rectum is. Our muscles are the two walls on the side. In a perfect setting, this is a very narrow room. In a woman who's had a baby, a big baby, the room is wide. And so our ability to squeeze those muscles are the pelvic floor exercises, our contractions. As we get bigger and heavier, you put more and more stress on those muscles, and they can't compensate. So sometimes the organs start to protrude, and they actually go out the door.
My sister is a nurse, and when she told me, and that's prolapse.
Correct.
When she told me about, I couldn't believe that. I didn't think it was humanly possible for that to happen, but it does.
It is a discovery for many women that is surprising and scary at the same time, oftentimes found sort of serendipitously when they're wiping or when they're in the shower. And, you know, the brave woman will take a mirror and look and say, what is that? It looks like I'm giving birth. So it is one of those things that's very common. It doesn't usually hurt, but it presents, oh, here, I'm a bulge. And most of the women who have it, but we don't often find it until after it comes out.
Well, let's talk about some procedures that are available right now to help deal with those issues. What's out there?
So if you want to start with like non-surgical, because I think that's the best place to start.
Yes.
For us, I mentioned pelvic floor exercises, and a lot of people are familiar with Kegels.
Yes.
And they've been traditionally taught to contract their muscles when they're in the bathroom to find those muscles. We don't recommend that because the bladder's goal is to either be full or empty, not to stop and start and stop and start. And so it's a way to identify the muscles, but not necessarily keep doing those over and over again. I usually use the example that you're contracting your pelvic floor like you're doing a sit-up without moving. You're tightening up everything and pulling it into the middle, and that'll help contract those muscles.
Say that one more time.
So if you're doing a pelvic floor contraction, it's almost like you're doing a sit-up, but nothing's moving. You're just tightening everything up like I'm doing one right now.
Oh, okay. And nobody knows.
Right. But some women just don't get it, and so they need extra help. So they have sort of personal trainers for your pelvic floor. We have pelvic floor physical therapists, and they are really kind of the ambassador for the pelvis because they really empower you to learn how to do those exercises properly, when to do them, help you retrain your bladder. So all the things that we've done to sort of undo proper bladder training, they help us reinstill it in our teaching.
Can you retrain your bladder?
Yeah, you absolutely can. If you don't have neurologic or muscular damage to the point where the nerves won't receive these signals, absolutely, you could retrain your bladder.
Wow.
And keep a lot of people out of the operating room, especially if they start early on.
So in addition to that, there are also other procedures.
Yeah, so there's lots of medications out there. You've probably seen a lot of those on TV, and I won't go into a lot of detail, but those are specifically for people who have that gotta go. I gotta go to the bathroom right now. I can't hold it. I'm gonna pee on myself if I don't get there. It's not for the patient who has cough, laugh, sneeze, I'm jumping on a trampoline and I leak, or I bent over and a little urine came out. So those are generally for patients who want to do exercises, and if we have to go to the operating room, we'll tend to do a sling.
And what is a?
So think about a sling like a hammock for the urethra. It just kind of suspends it just behind the bone so that when you cough, laugh, or sneeze, the urethra doesn't drop down and open up. Does that make sense to you?
Yes.
Okay.
What about the person who says, I don't want to have to wear those pads
Correct.
for the rest of my life?
Yeah.
But they've modernized those so much that they're not big diapers, you
right.
know, like
right.
that they were in the past. They're not
yeah,
big.
because
it's something
you
that
could see them, you could smell them, you could hear them when people will walk sometimes. So
yes,
they have modernized them significantly, but not everybody wants to. And most of our patients in the past would wait years and years and years before they would come see us, and so they would tend to be a little older. Now women are saying, I'm not going to have this problem in my 40s. I don't want to deal with this. And so they're coming to us earlier, not really accepting the idea that they're going to have to wear a pad for the next 40 years. So they want something done to correct some of the leakage, or at least improve it to the point where they could go from even just a big pad to a liner.
So what are women choosing for the most part?
For stress incontinence, I think my younger patients do tend to choose more surgical options if they have completed their childbearing. I think one of the rate limiting factors is that we don't like to do any procedures that are going to require reconstruction until you've had kids. If you're going to have more kids, another passenger sort of going through the pelvis is going to change everything that we did as a surgeon.
So if you, for example, you just mentioned reconstruction.
Mm-hmm.
If you have some sort of reconstruction, you can actually reconstruct mm-hmm. that area mm-hmm. now. How successful has that been?
So it depends on the procedure, and it depends on sort of the compartment that we're dealing with. Using a room example again, it's harder to fix the ceiling where the bladder lives, a little easier to fix the floor and where the rectum lives, just below us. And then sort of this back wall behind us is where the uterus would live, and that usually is fairly easy to fix too with some of the surgical procedures. And we can range. So one of the unique things about our subspecialty is that we do surgeries from the inside out and the outside in. We can do a vaginal procedure and move up into the pelvis, or we can do a robotic procedure and go from inside the pelvis down. And that gives us different perspective depending on what we're trying to fix and address and to what degree of severity.
Now, you deal primarily with women. You don't deal with men who also have a lot of, but of course the men and women are so very different in the way we're constructed, so they would be dealing with different issues.
So they don't have the same issues with regard to changes in their pelvic floor because they haven't had the advantage of childbearing. But even women who haven't had kids, it's just sort of one of our genetic and structural changes that makes us more vulnerable.
Well, who's more at risk? The woman who's had children or the woman who hasn't?
Definitely the woman who has had children is more associated with pelvic floor disorders, but not having children doesn't exclude you from having these issues too.
Okay.
Because there are even studies with nuns who present with issues with pelvic floor disorders, prolapse specifically.
I know I had my kids back to back. I had 3 pregnancies in 5 years. So it was back to back to back, and a set of twins in between. And the doctor said maybe some of the issues had to do with giving birth so close together.
Or just what were those births like? You know, a weight greater than 8 pounds, or a really fast delivery, or a really long delivery where you're pushing hours and hours and hours.
All that.
Or using
all of the above.
Check.
Especially with the twins, with carrying twins.
Yeah, that extra weight, and you're not just carrying the weight of the twins, you're carrying the fluid, the placenta, everything is being held by and cradled by the pelvis.
But the positive thing that I can say now opposed to 10 or 15 years ago, there's so much more information out there, and information is power.
Absolutely. You know, a lot of times patients will come in armed with information, and to me, some physicians will feel that that's a little bit intimidating or bothersome. But to me, I've got an educated patient that I just have to sort of realign with what is the current literature and what's true and what's not true. So I appreciate it when people have done research, or they will do research after I've told them about what condition they have. You
mentioned earlier that your recommendation is to go with the most non-invasive.
We try.
Methods first.
We try.
Are there any vitamins out there, or any more holistic things you can do to?
So it depends on the condition. Like for the overactive bladder, and specifically for some of the cystitis conditions, there are vitamins that really promote sort of a non-inflammatory environment, and so they can be very helpful to kind of calm the bladder down. I think one or the other, and I'm going to just stick this in there because estrogen has gotten such a bad reputation, and many women are like, don't even mention it. And
I'm one of those.
But we've been able to replace it through the vagina without having the systemic effects. So if you put a small amount, it's like putting lotion on your skin. You don't go into lotion toxicity.
No. Not that I've ever heard.
So that can sometimes sort of calibrate some of the issues that are happening within the pelvic floor. Because we know that the hormones promote collagen. Collagen makes the tissue stronger. It can also change some of the bacterial environment, so you're less prone to urinary tract infections.
So you're saying the estrogen of today is very different?
I'm saying the modified use of estrogens can be perfectly acceptable and not put you at increased risk of any kind of cancer or heart disease.
What about these probiotics we've been hearing so much about?
Yeah, so probiotics are very helpful for people who have bowel issues. We see that a lot as well, constipation, and in fact, I'm going to just stick this in there, no pun intended. Some women are surprised when I'm doing the exam and I ask them, do you ever have to put your finger in your vagina to have a bowel movement? Or do you ever have to push on an area to have a bowel movement? They're like, how do you know? And so one of the things we see very often when women have chronic constipation and they're straining and they're straining and they're straining, they start to stretch out those walls. And they develop a pocket that bowel sits in, and so it becomes harder and harder for them to empty their bowels. Probiotics are very helpful sometimes for women who have chronic constipation. Just kind of helps to manage some of the bacterial levels, increasing the good bacteria, decreasing the bad, but also for urinary tract infections.
So how often with bowel movements should you be going per day?
Sure. The range is up to 3 times per day is normal, and as long as every 3rd day. Most of us think you need to go every day. Every day.
I tell my kids, did you go? Mom, mind your business. But I didn't know that. I thought it was you needed to go every day. So it's not abnormal.
No, it's not abnormal. And if that's someone's pattern, that's totally acceptable.
And everyone has their own pattern?
Everyone has their own pattern. It's when they start doing heroic efforts to have a bowel movement, like they're climbing the wall to try to get the bowels out, or straining to the point where they feel like they're going to pass out. That's not normal.
Okay.
And you know, you've seen things on TV now. They're doing the we prescribe sometimes a squatty potty.
Yes.
Which is sort of the alternative to putting pressure on the area. You're just changing the angle of the vagina and the bowel to improve evacuation.
Wow. So in wrapping up our discussion, we still have a few minutes left. What's your best recommendation for people who are having symptoms?
Be curious about your symptoms and ask if they're abnormal. And if you're not getting the answers to your question, keep asking the question. And not just to your provider. Sometimes, you know, I've gotten so many referrals from patients, from other patients, who heard about me at the gym. Or they heard about me, you know, they were getting their hair done and they were talking about, you know, these issues, and all of a sudden this came up. So be curious and ask questions. I think that's the most important message I would ask, because these are very common conditions that we don't have to live with.
And we don't have to be ashamed of.
No, not at all.
Either.
Not at all. Especially since there are options for fixing them.
And you can still live an active life.
Absolutely.
When you've got these issues. You can still go to the gym.
You
can
church.
still go to church. You can still swim. You can still do all
Absolutely.
of the, you can live with it.
I had a 91-year-old patient come to me and say, I want surgery. And I said, are you sure this is the right decision? Thinking that I could end her life on the operating room table. And she said to me, and I think this is key, is, you know I'm 91, but I don't want to live like this anymore. And so when a 91-year-old, you know, was questioning her quality of life, I think it's time for us, even as younger people, to say, hey, you know, you don't have to live like, you don't have to wait till you're 91 either to get it fixed.
Yeah, absolutely. And as you were saying earlier in our discussion, you were talking about different foods to look at your diet.
Absolutely. Diet is diet, exercise, those are the things that we tend to go back to, and it's important for the pelvis, it's important for your heart, it's important for the entire body, but it's amazing what kind of impact our diet and exercise can have on keeping us healthy.
And that's what this organization is about. This is the Sisters for Fitness Wellness Show, but the organization Sisters for Fitness is focusing on getting African American women moving and eating right, because we see there are so many things associated with chronic illnesses associated with obesity.
And you don't have to be at the gym pounding, you know, lots of weight. Yoga, Pilates are excellent methods to help with core strength.
Indeed, indeed. It's been a pleasure talking to you.
My pleasure as well.
This is not our last time.
Okay.
We've been talking to Dr. Briana Walton. She is a urogynecologist with the Women's Center for Pelvic Health. Did I say that correctly?
You did. Thank
yes,
you.
With the Anne Arundel Medical Center.
Thank you so
glad
much.
to have you.
You as well. Thank you.
You've been watching the Sisters for Fitness Wellness Show. I'm Stephanie Gaines-Bryant. Have a great day.